to the cloud. And now I need to make host. All right, all you have to do is accept, sir.
All right, very good. Well, I'm going to start by sharing my screen. We'll go here. And hopefully you can see that. Okay. So what I can't see, unfortunately, is your questions that pop up. So at least not at the moment. Maybe if I figure out how to minimize this, I can.
If you hit escape, Dr. Eschelbach, it'll bring up where you can still see this screen, but see the chat room on the right.
Okay. Very good.
That work?
Pretty much. Well, still can't see the questions. I can see everything else. So.
Move your cursor back down to the bottom screen and click on the chat button to the right of the share screen button and see if that pops it over to the right.
It doesn't, so I'm sorry. What you can do is unmute yourself, and if there's a significant question, and just go ahead and ask, and we'll try and get this there. Or, Jane, you can let me know if there's a question.
Okay, we can do it either way, but if I miss it, that's a good thing. Unmute yourself, but remember to mute yourself back so that we don't pick up a lot of ambient noise with everyone's background noise. Sound good?
Sounds good. All right. All right, we're going to talk today about drowning and near drowning. Although you'll see, I put this in question marks, near or parentheses, because near drowning is kind of an old-fashioned term because drowning is kind of a continuum, and drowning is either a positive outcome or a negative outcome, meaning the patient lives or dies. So we'll go over this very quickly. This is a diagram of drowning deaths in the state of Oregon, the state in which I live. I imagine that if you were to pull up your state, I went on several different state websites and didn't find satisfactory information is outlined like this. But I think if you were to find that information wherever it's hiding, you would find that the distribution is going to be the same. If you'll notice, this is a bimodal distribution, meaning that the very young and the very old have the highest amount, and there is a few higher peaks in the middle for age groups. You'll notice that the majority of drownings occur between 15 and 25 years of age, and this is just plain old Darwinism. Males will drown more than females because females are just basically smarter than males in risk-taking, at least. Statistics that go back several years but are about the same per year, they haven't significantly changed, shows that about 1,000 children a year will drown, and about 60% of them will be less than 4 years old. Of 2,000 data from the CDC of the 3,280 unintentional drownings, averaging 9 people per day, and that's not including boating-related incidents. So these are drownings that are not involving some type of boating accident or mishap. In 2003, for every child who drowns, there are about 3 who will survive and need emergency department care for non-fatal submersions. And greater than 40% of these children will require hospitalization. And we'll go over that towards the end of the lecture. Now, here's the difference between some of the older terms and the newer terms. In 2002, they had a World Congress on Drowning. And drowning was defined as a process resulting in the primary respiratory impairment from submersion or immersion in a liquid medium. So that means all comers who go under the water or under some type of substance where they cannot breathe will have a drowning definition, regardless of survival. So if you go under the water, flail, survive, you're still a drowning victim. You're just a drowning victim that happened to survive. Drownings without aspirations do not occur. And I'll show you this a little bit on a chart. There's people who talked about dry drowning, and that really doesn't happen. All drowning eventually has some type of aspiration into the lungs. So terms such as dry drowning, wet drowning, active or silent drowning, or secondary drowning are all out. And even you'll see on the bottom right hand near drowning, which is why I have changed this lecture over the years to include the parentheses of near drowning, are really considered out. Here's another picture of my state of Oregon. This data comes from our statewide health department, but here's what I want you to pay attention to. Look at the black areas. These are age-adjusted rates per 100,000 people. And the areas where the black is are the highest concentrations of drowning. Now, Oregon is a coastal state, so you'll notice that all the way from the uppermost portion up in around the Washington border, all the way down to the California border, has the highest concentration, and that's where drowning occurs in those counties that are beach and ocean accessed. Two other areas, one right next to me, this area here is called Central Oregon, and Central Oregon is associated with,
Is that the one?
I'm sorry, Central Oregon is associated with quite a few reservoirs. So because of the reservoirs, highest concentration here in this area is where all the reservoirs are. You can see that we have the highest drowning. And then way out here on the other state border, this large county here is primarily because this border here, which runs on the Idaho border, is also part of where the rivers are, like the Snake River, etc. So there's quite a few areas, and common sense, people drown more in those areas where there's quite large bodies of water. The other drownings, of course, are related to pools, hot tubs, smaller bodies of water. Who's at risk? That's a really good question. And if you go back to the very first slide we talked about, we said there's kind of a bimodal distribution. Males account for about 78% of the drowning victims in the United States. Children, about 850 children ages 0 to 14 die from drowning each year. And although we've slowly declined those rates, it's still the second leading cause of injury-related death for children 1 to 14 years of age. The first cause is trauma, of course. African Americans, whether it's because of socioeconomic or access to learning how to swim or other socioeconomic factors we don't know, but age-adjusted drowning rates for African American is about 1.4% higher than the majority of other victims. 15% of the children who were admitted from the hospital wind up drowning. I'm sorry, let me say that again. 15% of the children who were admitted for drowning wind up dying in the hospital. And as many as 20% of the drowning survivors suffer some type of severe permanent neurologic difficulty. That can be something as simple as minor stroke-like symptoms to complete dependence on others. What are the drowning modalities? How does it happen? Children less than 1 year of age, primarily bathtubs, buckets, and toilets. I'll go over those in a few minutes. Children ages 1 to 4 are primarily swimming pools, hot tubs, and spas. and children 5 to 14 years old, swimming pools, and open water sites. So of the children, the majority of these kids who have at-home problems are the infants, and most of the times the infants are some of the most preventable, which I'll go over in a few minutes. Bucket drownings. Several years ago, I did a lecture on just these hazard stickers and where they came from and why, for example, as you're walking up a ladder, does somebody really have to put a sticker on it that tells you not to stand on a paint stand and that it's not a step? Well, unfortunately, people have done this and wind up getting sued, or companies wind up getting sued because these accidents occur. Around 300 bucket drownings have occurred in the United States since 1984. Usually the children are 7 to 15 months of age, average about 24 to 31 inches tall, and the bucket usually contains some type of water or nasty clean fluid or paint or something to that effect. Children are mostly head, meaning that they're top heavy in the head and their heads are larger proportionally than the rest of their bodies. So when they put their head into something, it weights them down. They don't have the core abdominal strength to pull themselves out, and they wind up as drowning victims. Tub drownings are also tragic. Approximately 10% of childhood drownings occur from the tub. Other sources of drowning for children are toilets, the 5-gallon buckets that we already talked about, bathtub, and diaper pails. Typically what happens is there is a lack of adult supervision. That's why I say that this is one of the most preventable deaths. Did tub seats help? That's a question, and in general, they don't. People have a false sense of security with tub seats, and they tend to walk away from their kids because their kids are sitting there fine, upright one moment, and they come back just a minute later, and the child is drowned. So bathtub seats are not intended or marketed as safety devices. Now, that's not to say that they're not safe. I've had 3 children, and I had a tub seat that I used with all 3 children. However, either myself or my wife was in the room at all times, in the bathroom at all times, while the children were in the rings. Bathtub drowning deaths of infants aged 6 to 10 months from 1994 to 98 were studied, and they found 40 infant drowning deaths associated with bath seats. 78 were not associated with bath seats, so approximately 45% of the infants in this group used bath seats. So the data suggests that either no protective effect or a slight protection may happen from unintentional bathtub drowning. Anyone who's ever had a child knows that you have to watch them every minute. There's something called anticipatory guidance. Your pediatrician or family physician should do it every time that one brings a child into the office for a well checkup. And that's when we start telling folks, this is what you need to look for. So a brand new baby, for example, will simply lay on its back and not move. At about 3 or 4 months of age, that's when they start to roll, go from the back to the front. And once they begin to go from back to the front, they can roll and other things happen. So they can roll off a bed, they can roll off a changing table. When children get older, they start to play with things, and they can put as noted, a fork in a electrical socket or something like that. So that's what anticipatory guidance has to do. So anyone who's ever had a child, or any mother or father who's ever had a child, you have to watch them like a hawk, or else they'll wind up doing things that are silly or stupid. And unfortunately, drowning is one of those things. Baby swim classes, do they help? Well, they're done to teach babies to float, not to swim. They are quite popular. They come in and out of favor. I think the majority of moms enjoy them because they get to bring their child to the pool and actually get to interact with their children in the water. There's never been a reported case of drowning while a child was in class. However, there are several reports of hyponatremic seizures following class. What are hyponatremic seizures? Well, anytime you drink in free water or too much free water, you wind up decreasing your sodium. That is a natural function of your kidneys. You wind up taking in too much free water and your sodium can go down. So a lot of these kids, even though they're not actually drowning or actually drinking water, they might put their face in. So it leads with a false sense of security is the basic conclusion. Baby swimming classes are good. They can teach a child to go from the back to the front, but in the majority of cases, if a child goes in and goes underwater, they're not going to have the brain power or muscle power to fight the drowning. This is a famous Nirvana cover that kind of brought that out. And this is my favorite Weird Al Yankovic cover as well. All right, let's move away from tubs and talk about spa drownings. Most residential pool drownings are in kids who are less than 4 years of age. Now, these children, primarily, there's 3,000 pool drownings that required hospital treatment each year. So these are the types that I'm going to see most often in the emergency department, and you as paramedics will wind up transferring most of these patients. Very often they were last seen in the home. They're missing from the site less than 5 minutes. That means mom or dad got busy doing something, whether it was reading, working on a project, or whatever. And as I mentioned before, anticipatory guidance says children will get in trouble. And in the care of one or both parents at the time of the drowning, of most of the time. Greater than 50% of these kids happened in a home pool, and 1/3 occurred in homes of friends, neighbors, or family. So most of the time, probably up to close to 80% of the time, it's somebody that your family knows. Since 1980, there's about, on average, 230 kids per year who will drown from spas or hot tubs. This is a very fancy study that was done that involves meta-analysis and control studies to evaluate pool fencing. A lot of fancy conclusions, but essentially what it concludes is you put a fence around a pool and the chances of a child drowning are significantly lower. So in-ground swimming pools without complete four-sided isolation are 60% more likely to be involved in drowning than those with four-sided isolation. There's two ways to prevent drowning with fences. One is to put a fence around the backyard that the pool is located in, but that's really not quite enough. If there's children who have the potential to be in the area, you have to put a fence around the pool itself. So really every pool should have two fences. They do make commercial products where an alarm goes off if there's a disturbance in the water, whether a bird lands on the pool or a child falls in the water. That's supposed to set off alarm inside the house, and even will send a text to a phone. But these are not foolproof either. Boat-related drownings. In 2002, the Coast Guard compiled data of all ages. This was the most recent study that I had access to. About 5,700 people suffer boating incidents every year. 4,000 approximately are injured and 750 killed. 70% of those fatalities are due to drowning. 30% of the fatalities are due to trauma, hypothermia, carbon monoxide poisoning, or other causes. Alcohol, this is a very interesting statistic, was involved in about 40% of the fatalities. Open motor boats, about 41%, and personal watercraft, those are the smaller ski-doos, etc., about 28%. If we go back to the alcohol as a cause and adult drowning, most of those are actually due to the fact that people fall into the water without protective life vests. So that's a very high statistic. And the majority, as we noted, alcohol is involved in almost 40%. So in this particular study, it found that alcohol was involved in 25 to 50% of teen and adult deaths associated with water recreation. Alcohol, of course, influences balance, coordination, judgment, and its effects are heightened by the exposure to the sun. So not only are you in the boat drinking alcohol, you're also becoming dehydrated as the sun kind of slowly boils you, and that alcohol concentration significantly increases. So the relative risk of drowning was 31.8 in all comers with a marked elevation in alcohol level. So that is essentially from a 99 study in the Journal of American Medicine. And what it told us is if you're going to suffer drowning, there's, as we noted, 25 to 50 in some studies. In our last study, we talked about 38%, and here 31%. So they're relatively high alcohol-related drowning deaths. Now here's a drowning sequence that I'd like to go over. Hopefully it shows up okay, but essentially what happens at the beginning of drowning? As I move my cursor up here, you can see that they're struggling at the very beginning. Struggling will lead to panic and breath holding. Breath holding will lead eventually to gasping. This is where the old concept of dry drowning came from. If you follow this down, you can have laryngospasm, that's spasm of the larynx, where the seal of the lungs is sealed off and it goes to the left here of dry drowning. That's where one of the original ideas about dry drowning came from. But we've never found anybody at the bottom of the lake who was completely dry and had no water in the lungs. What happens is eventually you get that reflex is abolished, and that leads to wet drowning. Now that very often in the gasping, you can go over into vomiting and immediate aspiration, which leads to wet drowning, or you begin to swallow water and then eventually lose your protective effects and you wind up wet drowning. So from beginning to end, the final occurrence is going to be drowning. What does the event look like? Well, first off, there's part one, which is voluntary breath holding. And that's, you get small amounts of aspiration of water into the larynx, and that causes laryngospasm. Sometimes it'll lead to a cough, or some people will actually cough and then swallow large amounts of water. Eventually, the laryngospasm will abate due to hypoxia, meaning you're not able to hold on any longer, and you aspirate that fluid into your lungs. Some people fall into the water, hold their breath, or they're in a boat and it capsizes and they can't get out, they'll hold their breath. Eventually, they'll run out of air and the laryngospasm will abate and aspiration will occur. The second part of the event is you get a decrease in saturation, meaning your oxygen goes down. You'll get a decrease in cardiac output. Intense peripheral vasoconstriction will happen. That means all your vessels will shut down and constrict. This can lead to hypothermia, meaning your temperature can go down. The heart rate will slow significantly. If it goes slow enough, you go into a bradycardic rhythm, and this eventually will lead to circulatory arrest, such as VFib or one of the other cardiac dysrhythmias. Extravascular fluids can shift during this time, so your kidneys can start shifting, but most of the time, your time is very, very short, and in less than 10 minutes, most people are already deceased from the drowning event. Let's talk a little bit about a diving reflex. We know a diving reflex when we talk about it for a few different reasons, primarily survivors of cold water drowning and a way to treat PSVT. We've all heard of treating PSVT with immersing somebody's face in cold water, and that has to do with the diving reflex. What does the diving reflex come from? It's a mammalian response, meaning all mammals have it, but some of the more famous mammals like whales, porpoises, and other large water mammals wind up going deep into the water, and as they go into the water and it gets colder, their heart slows down, their lungs slow down, and the metabolic rate slows down so they can actually stay underwater longer. It's really quite weak in humans, but children are a little bit better at it than adults are. It occurs when the face is submerged in very cold water, usually less than 20 degrees centigrade. Now that's where, as you read through your SVT protocol I talked about, that sometimes you can break SVT by putting somebody's face in cold water. SVT is a superconductive pathway, and when you put somebody's face in a bucket of cold water, it causes a diving reflex. The heart rate will slow down. I've used it successfully one time in treating a child with SVT, but most of the time either it doesn't work or people panic and the heart rate remains high. When we're talking about drowning victims, a diving reflex also can occur. And the extent of neurologic protection in humans due to the diving reflex is likely very, very minimal. However, you'll hear a case on the news every winter about a child who was protected or lived despite a diving reflex and drowning. So we'll talk about that in a minute. So what happens when you're drowning is you get something called asphyxia. That means you're not breathing. Hypoxemia means you're not getting enough oxygen. Hypercarbia means you've got too much CO2 in your body. And metabolic acidosis happens when all of these things go together. Hypercarbia, too much CO2, will drive you towards acidosis. Does it make a difference of fresh water versus salt water? And the answer is not really. Some people have talked about an advantage of freshwater drowning over saltwater drowning as far as the effect on pulmonary tissues, but really for survival, we don't see that much difference. There is a difference in drowning in very high mineral content water, something like the Dead Sea or perhaps in Utah, Salt Lake, with a very high mineral content. There might be a small difference in outcomes. All drowning will lead to some hypoxemia, meaning not enough oxygen. You wind up with occlusion of the airways with water and particulate debris. This is the stuff that's floating in the water. Unless you're in a particularly clean pool, most of the time there's stuff floating in the water. This causes a change in surfactant activity. Surfactant is that substance that's secreted by healthy lungs that allows the lungs to stay open. When you take a deep breath and you hear a little pop when you're listening to somebody's lungs, and that little pop is indicative of when patients take a large deep breath, that little pop is indicative of the smaller alveoli opening. It's surfactant that allows the cells to become less sticky and keeps those alveoli open. So when you drown and you have hypoxemia and water, that decreases surfactant activity and the lungs are not able to stay open. Bronchospasm happens just like in wheezing or asthma. Bronchospasm can occur. Shunting in the heart will occur, and the dead space in the lungs is increased, so there are less active lungs to actually work. So the lungs become smaller and inefficient. The second part of this pathogenesis is the cardiac arrhythmias. The heart is a pump, and if it's not pumping well and easily and hard, the top to the bottom, then the rest of the body's not going to get sufficient pumping. If you don't have fresh oxygen coming in, the cardiac activity doesn't matter because eventually you run out of oxygen. Hypoxic encephalopathy is something that happens when we don't get enough oxygen to our brain. This is evident in victims of codes or drowning or anybody where we don't get circulation restored quickly enough. The brain is probably the most sensitive tissue to hypoxia, and you can wind up with brain damage. That's why strokes are so devastating. Renal insufficiency can happen. That means your kidneys can shut down. But again, in drowning, we don't have much time to see that. Global brain anoxia means your brain is not getting enough oxygen at all, and you can wind up with your brain swelling. Some of these effects, hypoxic encephalopathy, renal insufficiency, global brain anoxia, we'll see in survivors, and they may lead to whether or not a patient lives or dies. So now we're talking about survivors. What are the signs and symptoms of survivors of near drowning or drowning victims who have at least made it out of the water? 75% of kids who will develop symptoms will do so within 7 hours of the event. Why is this important? You're called to a drowning at a house. You pull the child out of the water. Maybe you give a few quick breaths and start CPR. The child coughs water out, and in 5 minutes' time, they look great. Is that child safe? Probably not, because all that damage we just talked about in the prior few slides, the surfactant, the particles, all that, the body's already fighting a battle to keep the healthy lungs and the lungs remaining healthy. So 75% of the kids who develop symptoms will do so, and they'll do it within 7 hours of the event. That's why I recommend all near drowning or drowning victims who survive be checked out in the hospital. They can be anywhere on the spectrum from coma, meaning completely unresponsive, to agitated alertness. They may have some cyanosis, whether central around the lips or peripheral in the hands, coughing, and the production of frothy pink sputum. Think back to congestive heart failure. What happens in congestive heart failure? The lungs fill with water. That water causes bursting of the small alveoli, and you wind up with pink frothy sputum, meaning spit and blood and sputum mixed together. And if you see pink sputum in a patient who is the survivor of a drowning fatality or near drowning fatality, then this is the type of thing that they're going to show. They're going to be like a congestive heart failure victim. They're going to have fast breathing and fast heart rate, tachypnea and tachycardia. They may already be developing a low-grade fever as their body's trying to respond to the insult of the injury. And there's also signs associated with trauma to the head and neck. And you should be very, very careful. And we'll talk about those in a few minutes. So what is the pre-hospital treatment? What do I do as a paramedic? Number one is rapid and cautious retrieval from the water. Safety first, meaning think of yourself first. I'll show you a case study at the end where paramedics thought safely and retrieved a drowning victim. But if you yourself jump into the water and you don't have your team ready, or you don't have a way to protect yourself, then you're going to wind up a victim as well. When you get any drowning victim in, immediately assume that there's a C-spine injury. You want to establish an airway. When you do so, maintain C-spine precautions. I'll talk about that in a few slides. Breathing can be mouth to mouth, bag valve mask as long as you have good seal. Intubation can be helpful, but supplemental oxygen on all patients. All drowning victims need supplemental oxygen. Why? It's easy. They've got damaged lung tissue. They've got decrease in the ability of the lungs to work properly. So any help that you can give is important. The old meanings of abdominal thrust are kind of out. It remains controversial, but really if you look at it, it's not really a good thing. That means the old knee to chest, putting them in a gravitational drainage versus no treatment at all. When they are studied, you really have no change in survivability when you try and do these things. And it really delays ventilation and transport. What these patients need is oxygenation and treatment, whether it's aerosolized bronchodilators or oxygen, and really for severe victims, it's going to be positive end expiratory pressure. I'll talk about that in a few minutes. But abdominal thrusts are essentially a waste of time. You can get regurgitation and vomitus, and that can lead to pulmonary aspiration. So now you don't only have water aspirated into the lungs, you wind up with food particles and stomach acid in the lungs, which can worsen the whole scenario. CPR, of course, should be done right away. This isn't a class in BLS, so I'm not going to harp on CPR. And you're going to transport these patients as soon as possible. So this is the important thing. Any patient with a significant episode, including those who are asymptomatic at the scene, should be transported to the hospital for evaluation. One of my favorite shift commanders, when he was talking to his EMS paramedic, said, "You have a duty to terrify." What that means is if you have somebody with something like drowning and the patient doesn't want to go to the hospital or the parents think the child is fine, your duty as a paramedic is to inform them of all the possible things that can happen, including delayed brain damage, delayed lung injury, all this stuff. Leave it up to somebody like the hospital physician or extended practitioner to make the determination whether or not somebody is safe. Usually we'll hold on to these kids at least 6 to 8 hours in the emergency department, especially if they have signs and symptoms that are evident. If they have any abnormality in their chest x-ray or physical exam, I admit these kids. And my duty to terrify is if they want to take a child home, can't we take them home? I said, no, you fall asleep, this child falls asleep, he could be dead when you wake up in the morning. So any patient with a significant episode really should be evaluated in the emergency department. In-water CPR is very, very ineffective. You'll see it in movies, but there's really, you've got nothing to push against, so get that person out of the water as soon as you can, get them on ground to begin CPR. And near drowning victims aspirate sometimes just small quantities of water. Postural drainage or abdominal thrust is unproven. We've already talked about that. So don't use Heimlich maneuvers or postural drainage or abdominal thrust to get the water out of their lungs. When you're doing CPR and providing oxygen, patients, if they return to a spontaneous circulation, will cough, and they'll cough that fluid out of their lungs. Watch out for concomitant traumatic injuries. This was a great study done in the Annals of Emergency Medicine about 12, 13 years ago. Of 143 drowned or near drowned kids, the median age was about 3.8 years. 30% had some kind of pre-existing disease, whether it was some type of developmental delay or some type of palsy, perhaps cerebral palsy. And then 5% had traumatic injuries. So nearly 35% had some type of medical disease or traumatic injury. Of the 5% of the traumatic injury, almost all were boys, surprise. Little bit older, 13.5 in years, and 6 of 7 had C-spine injuries from diving. So when does somebody drown? How does somebody do this? The typical scenario or a case that you might have in one of your paramedic classes is 13, 14, 15-year-old, maybe a 17-year-old child who dives off a diving board or dives into a lake and doesn't come up. Eventually, his friends realize that he's potentially drowned. People are called to the scene. People look for him. They might find him and then drag him up onto land. Why did he drown? Most kids that age can swim, and they wouldn't be diving in the water unless they knew how to swim. What happens is they dive in, they bring their hands down, and they hit the top of their head. They cause a compression fracture or a dislocation like you see here. They become instantly paralyzed, and they're not able to get out of the water. That leads to hypoxemia and drowning. So what do we do with drowning victims? What do we do with drowning victims that survive? In the upper right-hand corner, you'll see this is a chest x-ray of a child who is a drowning victim. You can see a normal x-ray. All of this material here will be black in a normal x-ray, filled with air. There'll be little specks of white, but you can see that generally, here's a heart, here's a diaphragm. They're supposed to be white, and this area of the lungs is supposed to be black. What happens in the lungs is when they fill with water, these pulmonary capillaries and these pulmonary cells begin to leak, and you essentially drowned again. That's where the old term of secondary drowning comes from. So therapy, these people need CPAP or PEEP. Most of you carry positive pressure airways. Most of you have some type of CPAP or BiPAP. If I intubate a patient and they're in my emergency department on a ventilator, I add something called PEEP, which is positive end expiratory pressure, meaning at the very end of filling up their lungs, I give a little bit more pressure, a little squirt of air that will open up the lungs as well. CPAP does the same thing. When you put a CPAP mask on somebody who, whether it's an asthmatic or COPD patient who's starving for air, that little bit of positive expiratory pressure keeps those lung tissues open. You can go ahead and use albuterol or Atrovent. It doesn't matter which. You know, that's your ipratropium bromide or your Ventolin for bronchospasm. Bronchoscopy is something I'm going to do in the hospital, where I'm going to put a scope down and suck water out of the lungs and look for particulate matter. That's done by a specialist. Antibiotics have not been shown to be beneficial, so if I see a x-ray like this, I'm not going to start this patient on antibiotics right away thinking that I'll prevent pneumonia. And steroids are not helpful. So, meaning in the hospital, giving them steroids is not going to be efficient. What are the bad prognostic indicators? What are the signs and symptoms that a child or an adult is not going to do well? They're primarily if they've been submerged for greater than 10 minutes, if BLS took greater than 10 minutes to get there, if CPR was longer than 25 minutes and the initial Glasgow coma score was less than 5. Age less than 3 years, if CPR has to be continued in the emergency department, a blood gas of 7.1, that's severely acidotic. A normal blood gas is about 7.4. And when their core temperature is less than 33. These are all bad prognostic indicators. Will the child die? That's a really good question. This is out of a text, emergency medicine text, and it has a grade of 1 through 6 and estimated mortality. So if a child after a drowning incident has normal lung exam, chances of mortality are pretty low. Abnormal lung exam could mean anything from wheezes to crackles, usually around 1%. If I see pulmonary edema, like I would in congestive heart failure, that could go up to about 5%. If I see pulmonary edema with low blood pressure, mortality goes up to 20%. Respiratory arrest means they stop breathing entirely on their own. Maybe they still had a pulse, but they weren't breathing. Mortality in that situation goes up as high as 50%. And of course, if CPR is, and along with CPR, you're going to have cardiac arrest, death rates go as high as 90%. What's the neurologic prognosis? Meaning, what will the final neurological outcome be? And if you do not have spontaneous respirations, that's an obvious sign. Go back here, we said that's 40 to 50% death mortality. Permanent neurologic sequelae is persistent in about 20% of the victims who present comatose. So if the patient is comatose on arrival, the chances of serious brain function, whether it's quadriplegia or other serious sequelae or effects, is pretty high. Does icy water help? Well, usually hypothermia is an unfavorable sign. So we went 2 or 3 slides back. We said that less than 33 degrees is an unfavorable sign. But there are several anecdotal reports every year where we have recovered after prolonged icy submersion. Every year on Lake Michigan, for example, with ice on the water, some child will walk out onto the ice. They'll take over an hour to find him, and there are anecdotal reports that the child is brought back from essentially death. Those are relatively rare. But for hypothermia to be protective, the core body temperature has to be very, very quickly reduced. So essentially, when that child falls into the water, they have to become extremely cold very fast. That's why adults tend to not get this diving reflex break, because we tend to be larger, we tend to have more fat, and kids lose temperature a whole lot quicker. So it's easier for kids. They have a high body surface area to mass ratio. Remember I talked about that when I said the kids are mostly big heads walking on little bodies. And they have less subcutaneous fat for insulation. Moderate hypothermia is a core degree of 32 to 35 centigrade. All shivering will begin to decrease at that age, or that temperature, I should say. And severe hypothermia has a core body temperature less than 32. Shivering stops and the cellular metabolic rate goes down. It's these people that they're quickly in this core 32. These are the children who usually have some chance of survival if they're going to survive at all. Cold temperature is effective in protecting the brain from anoxia for 75 to 110 minutes in controlled circumstances. So what do we do with severe ROSC victims, somebody who has, this is outside of drowning, return of spontaneous circulation, and we shock them and they're still unconscious? We still do cooling. We freeze these people, not freeze them, but make them very, very cold, get them down to 32 to 34 degrees as quickly as possible, and keep them in an induced coma so that all those bad metabolites in their body don't release. And then we slowly begin to warm them. So this is the same thing in drowning victims. You get some protective effect from the hypothermia. Once cell death from hypoxemia occurs, though, there's no protective treatment from hypothermia. So once a cell dies, it's dead, and unfortunately, no matter how cold you make them, they're not going to be protected. So hypothermia, surface cooling alone cannot decrease a core temperature fast enough to yield protection. So blankets and cold things will not help hypothermic drowning victims. The cooling rate in drowning victims, it's difficult to estimate as they might be actually swallowing water as well as breathing cold water. Hypothermic protection involving surface cooling only would seem to require submersion in icy water. So when these people do survive, it's usually when they drown in icy water, not just cold water. Few cold water victims have significant brain protection. It's more likely than not to be an unfavorable prognostic sign. King County, that's up in Seattle, the water is cold, but it's rarely icy. And they found that hypothermic protection was not observed in most of those patients because they had a core temperature of greater than 34. Went down to 32, you might have some protection. In Finland, they did a study where the medium water temperature was around 16 Celsius, and people who had submersion duration less than 10 minutes had the greatest outcome, even in children. So even though cold water can be protective, getting them out of the water and oxygenated is the best treatment. How do you rewarm them? When we do rewarm them, we only rewarm them slowly, 1 to 2 centigrade per hour. Mild, moderate, and severe are the types of hypothermia that can be seen. You may see some of these changes in, we can talk in another lecture about hypothermia, which is somewhat related to cold water drowning, but there are 3 phases of hypothermia as well. Keep in mind that you may see some of these things like J waves. That's kind of a board type of question, but when you're taking your exams. But keep in mind that mild, moderate, and severe hypothermia have to do with the degrees, and these are degrees in centigrade. What happens in warm water sites? Well, essentially, the news is that most of these drownings are warm water across the world. 80% in pools, bathtubs, lakes, or ponds. We've already talked about that. 63% are males, aged 6 months to 15 years. What response is important is bystander resuscitation. In 80% of these patients was seen in one study. Average EMS response time about 6.8 minutes. That's really pretty good. When EMS arrived, 28% of these children were in cardiac arrest and 5% were in PEA. That's quite a high number. Paramedics did CPR in 87 out of 89 of these children. I'm assuming the other two kids either were awake or actually had been under for too long. And 20% of those with CPR no longer needed CPR when they reached the emergency department. And keep in mind that we said survivability a few slides back, that if CPR has to be done in the emergency department, there's a significant decrease in survivability. So if CPR is being done in the emergency room, not all hope is lost, but most hope is lost. Paramedics intubated 19 of these children and used epinephrine on 30 of these patients. The bottom line is 80% of those in arrest at the scene arrived in the emergency department in arrest. 13 were in PEA, 5 deteriorated, almost all received epi, and the final result is many of these people did not survive. CNS had those survivors, persistent vegetative states in 15 out of 185, initial Glasgow Coma score of 3 in kids, only 14 survived intact, and 51 patients have subsequently died with neurologic side effects. So of the patients who had neuro side effects, quite a few, 51 patients wound up dying. All intact survivors demonstrated some type of functional recovery within 48 hours. So if you're going to have a survival and you've got severe central nervous system problems, if you're not better within 48 hours, chances are you won't get better. There was a study that showed 6 studies reported functional recovery in about 17%, the overall average of victims who required CPR in the emergency department. So there is some talk of holding or withdrawing therapy from kids who have a low probability of functional survival. Excuse me. We really wind up not doing this. We try and do the best we can with children, intubate them, keep them on a respirator, hoping against hope that they'll get better. The majority of them, however, will not. There are anecdotal experiences of severe recoveries. Every year in the news, you'll hear about 1 or 2 of them. Those are great stories. So that's why most people are against withholding or withdrawal of therapy in kids who have this survival, at least to the emergency department, and we get spontaneous return of pulse. Most of the time, people want to try everything they can. So, final recommendations: pre-hospital resuscitation, including early intubation, ventilation, vascular access, and administration of ACLS medications is recommended. Continue resuscitation and stabilization in the emergency department. And then full supportive care in the ICU for a minimum of 48 hours. And consider withdrawal of support if no neurologic improvement is detected after 48 hours. So these are the recommendations for all drowning victims. And those that survive, who at least survive with retention of and return of a spontaneous pulse, keep them for at least 48 hours. All right, so here's a family history of one of my EMS cases. Sun River is about 12 miles south of me here. It's a resort town. It's open in the summer and winter. We're close to the mountains and skiing, so people go there as much in the summer as they do in the winter. So fire rescue was called to the scene of a cold water immersion. Apparently, the family dog ran around 30 feet from the shore onto the ice behind the resort's nature center, where the family was out taking a walk. The family was a dog, a mom, a dad, and a young teenager who was in a wheelchair, who was confined to the wheelchair and could not move from the wheelchair. So once the dog fell into the water, the husband walked out onto the ice to rescue the dog, and he too fell through the ice and could not get out. So the wife, of course, seeing that her husband fell in and the dog fell in, went out after the dog and the husband, and she left her handicapped daughter in the wheelchair on the shore, and she wound up falling into the ice as well. So the daughter, of course, not being able to move her wheelchair, nor wanting to, was the only one left on the shore as she screamed loud enough to alert a nearby visitor who called 911. So paramedics arrived and they dressed appropriately. So here's one of our paramedics. Remember, I talked about rescue, that you have to protect yourself before your victims. So a full suit was donned, protection and helmets, etc., are done to protect the paramedic. And they arrived on scene. 3 patients were emerged in 30 feet from shore in the cold water. The crew used throw bags to reach the wife, as well as flattened ladders, and they were able to pull her to shore. The husband was also reached in the same manner, and he held on to the dog as he was pulled to safety as well. Now, both the husband and the wife were transported to the medical center by here at St. Charles, one of my sister hospitals in Bend. The husband's core temperature was 89.4. The wife's core temperature was 91.4. And as far as the dog, he did fine. Nobody knew. He was fine at the scene, so we don't know what his temperature was. So here's some questions. You know, if the average dog weighs 60 pounds and falls through the ice, what are the chances that a husband weighing 190 pounds or a wife wearing 135 pounds would all stay above the ice? The answer is they probably should have just waited. Although these people did not submerge, they were victims, cold water victims, and hypothermia did set in. So that's why I kind of include that on my drowning lecture. So what do I do in the hospital when I have a clear spine or when I have a drowning victim? First off, I need to clear the spine if I can. If not, I'll keep them in a collar. Laboratories, x-rays, EKG, all these things are things that I have to do. You can see the bucket list of things that I have to do. Oxygen, high flow oxygen. I'll consider intubation if they're having any difficulty or their clinical course looks bad. I'll provide the PEEP that we talked about. We'll put a Foley catheter in because we want to measure what their output is. We want to monitor their oxygenation, do frequent checks on their electrolytes, check their temperature and their volume status, and keep going. So you can see all the things that I have to do in the emergency room just to get this patient either to survive or into the hospital. Basic lessons to learn, learn to swim, always swim with a buddy. Alcohol and swimming do not mix, although, as we know, people will do that. Watch out for the terrible twos. You're too tired, too cold, too drunk. Wear approved personal flotation devices when you're boating and fishing. Learn CPR. Don't leave children unattended near the water. In the home, if you've got wading pools, buckets, make sure they're empty. And don't overload your boat and equipment. All right, so that is a signal that I'm done. And any questions? Let me stop sharing my screen and I'll see if you have any questions out there.
What I suggest is if you have a question, type in a Y, and then everyone will see the order, and in order you can unmute your microphone and ask your question and remute, and then we'll move on to the next one. Surely somebody out there's got something.
I'm good. All right, great.
Well, there's one. Come on, everybody pipe up and say something. At least I know you're still here and didn't disappear, like turn it on and walk away, and you only get credit if you're still here. Ah, there you go. What is the biggest mistake you see paramedics make, I assume with drowning victims or drowning patients?
Sure. The biggest mistake I'll see them make is probably, we talked about that failure to terrify, is I know you have protocols for allowing people to refuse care. I really think that the best thing that you should do is make sure that you can get these victims in for evaluation. The second problem I might see is not protecting themselves, heroics. You want to make sure that you don't jump in the water alone if you're a paramedic, that's going to be obvious, and that you're protecting yourself. Next, very informative, thank you. And it says yes with drowning victims, and I'm not sure what that means other than...
I said when he asked the first question, I said, I assume he's talking about drowning victims.
Yes. So those are the biggest mistakes. Again, a lot of times, thankfully, these people look good. Very often, they look better than they are because it takes a while to get these changes to happen in the lungs. When I see a kid who's a near drowning victim or a drowning victim in the emergency department, I watch them in the ER, sometimes 4 or 6 hours. I might repeat a chest x-ray if there's anything abnormal. If they're wheezing, requiring anything like albuterol treatments, I just call pediatrics and get them in. Here's a question, mild, moderate, and severe. See if I can go back to that. Give me a second. Sorry. All right, I'll share this with you again. Oh, I gotta do it first. Sorry. So there's your mild, moderate. Mild is 32 to 35 degrees. Moderate hypothermia, 28 to 32. And severe hypothermia is less than 28. There is a saying that you're not dead until you're warm and dead. And that has to do primarily, perhaps in the near future, we'll talk about hypothermia. That has to do with hypothermia, whether it's drowning or just plain hypothermia. And that means that you try and get people warm before you could declare them dead.
It looks like Elizabeth asked further up, is hyperbaric oxygen therapy showing improvement in anoxic brain injuries?
Boy, that's a really good question. And the answer is probably not. Hyperbaric medicine has some pretty limited usefulness in emergency medicine. We use it for carbon monoxide victims who are not improving quickly. Surgeons are using it an awful lot to improve wound healing, but there's really not a lot of great data out there that says hyperbaric oxygen is great for brain injured patients. So although it seems like it would be great, it's not a great idea. It doesn't work.
Rochelle says, do you have any idea what the mortality rate is with drowning victims in contaminated waters, such as the current situation?
Well, I would say it's drowning in contaminated water is equal to drowning in fresh water or salt water. It all depends on the drowning itself is going to happen as soon as you're immersed. What does happen in contaminated areas like Houston is, remember we talked about those particulates. If those particulates get in and, you know, it's bits and pieces of fiber that are floating or, you know, grass matter that are floating, they can get into the lungs, they can seed the lungs, and they can bring whatever bacteria is on the surface of them into the lungs. The people who do survive, they can wind up with secondary pneumonias, and that's somebody who's in the ICU on a ventilator a couple of days down the line. So the mortality, I don't know what the absolute mortality is in dirty versus clean, but the majority of victims who drown in fresh water versus salt, they're about equal. In severe situations where there's a lot of particulates in the water, those are the people who wind up with secondary pneumonias. All right, let me see. A comment here. I would think with everything that's going on in Houston, it's going to be more of an issue of being exposed to Hep B and Hep C. That's probably true. That's more of a problem than drowning. But there were plenty of folks who did, you know, some of those heart-wrenching pictures you saw of the old folks in the nursing home sitting in their wheelchairs. That was kind of sad. What would be the first action to take on an unconscious drowning victim with a pulse on scene? Well, that's a great question. What would I do? All right, first thing I would do is put a C-collar on them because we don't know, we talked about associated injuries. Second thing I would do is high flow oxygen as quickly as possible. I would get a bag valve mask going. I would, when I say high flow oxygen, that implies a bag valve mask. I would also get suction if we can. Now, the majority of suction that you guys carry, they're not really great. They're kind of handheld things where you squeeze and you let go. If you have some rigs I've seen where they actually have a great suction device, if you can suck out anything, that would be great. But don't waste time getting high flow oxygen by bag valve mask. If this patient's unconscious, you're going to get yourself ready for intubation. And that would be the first thing I would do once I go through my ABCs. If they're breathing spontaneously, I would use a bag valve mask to assist, and I would consider early intubation. Let me see any other questions. No, I think that's all.
I think that's it. All right, I am reclaiming the host so I can turn the recording off.